I'm very pleased to see all of you here at this event, and it's a special event for me. I should introduce myself. I'm the acting director. I'm Shannon Brownlee, and I'm the acting director of the Health Policy Program here at New America. And I'm really pleased to have this event with these participants, who I'll introduce in a moment. And I'm pleased because healthcare reform has just started. I know we went through an incredibly painful and tumultuous 2 years in the passage of the act last year, but we really still, the hard work is still to be done, and that's the delivery system reform work. And so what I'd like to talk to you about today is the importance of understanding how the healthcare world really works. And that's one of the things that Jack Wennberg has been doing for the last 40 years in his career is explaining how the healthcare world really works. Not how we think it works, not how we assume it works, but how it really works. So I'd like to introduce Jack first, and then I will get up and introduce our other two speakers. But I've known Jack for, I think I met you in 2003 when I first did a story on unnecessary care for the Atlantic Monthly, and went up to Dartmouth, and the team of researchers up there spent 2 days with me, just incredibly generous with their time, walking me through this very counterintuitive information and these very counterintuitive analyses of Medicare data. And since then, I've been involved with the work there, and I think it's some of the most incredibly important work that we've got going in healthcare health services research today, and a lot of other people think so too. So Jack's book is the kind of reason that we're doing this event today. It's called Tracking Medicine, and it's available for sale after the event, and I encourage you to pick up the book and to actually read it. It is a fascinating book. It's the story of the research and Jack's path through this incredibly complicated thicket of information, but it's also very readable, and it has some extremely important and absolutely crucial messages, especially now, in an era where we're finally coming to grips with the budget deficit and finally coming to the grips with the fact that healthcare is the single most important discretionary spending, entitlement spending that we have to do something about in the federal budget. So Jack Wennberg is officially the Peggy Y. Thompson Professor in the Evaluative Clinical Sciences at Dartmouth, and he's the founder and director emeritus of the Dartmouth Institute for Health Policy and Clinical Practice. He's been a professor in the Department of Community and Family Medicine since 1980 and in the Department of Medicine since 1989. But that doesn't really convey what Jack's work has done and who he is. He and his colleagues developed a method of analyzing healthcare services in areas, and they recognized that there was enormous variation in what patients were getting in different places, and it had more to do with the suppliers of the services than it did with what the patients in those particular areas needed in terms of how sick they were. This was a really counterintuitive idea and tremendously important. So one colleague of ours, Ron Susskind, calls Jack the Copernicus of the medical world. And it's true in two ways. It's true in terms of the revolution that in thinking that his work has brought about, but also in terms of the resistance to it for a long, long time. It's now getting the kind of attention that it really deserves. So I'm very pleased to welcome Jack to come speak to us about how we control healthcare costs and get better quality.
Thanks. Thank you, Shannon. Copernicus had a little trouble getting a constituency, so I don't want to overpromise what you might get out of today's presentation. But the topic that I've been asked to comment on is the whole question about bending the cost curve. How could we, given the information that we now have about practice variations, how might we structure a response that might have some broader appeal than on the red or the right side or the blue side of the fence? And So I've tried to concentrate on those kinds of issues, but I'm going to do it within the context of the book that Shannon mentioned, and also to start with what the three of the four major kind of conclusions in terms of policy conclusions was that the practice variation that we see in surgical procedures, epitomized by surgical procedures, but including such things as diagnostic tests, certain drugs, and so forth, where what's really at stake is an option, a choice between one or more, two or more treatments. That in these kinds of practice variations, what we really need to do is to get the patient centrally involved in the decision about what's done, both from the point of view of understanding what's at stake, but also from the point of view of understanding what the values are of that patient, the preferences of that patient, as opposed to the average patient. So this is very much a patient-centered concept, and it's a concept which should have broad appeal across all spectra of the political spectrum today, it seems to me. The second kind of major conclusion is that we need to promote organized care, and by organized care, what I have in mind are places like the Mayo Clinic, places that are group practices, places that are well enough organized so that one can take care of patients over time and have team medicine as a possible solution to the disorganization that's out there now. And this is more of a response to the strong story that we've developed in the Medicare database that much of our problem is how we manage acute and particularly chronic illness over time. And to do that, we've got to have some sense of organization. And the third major conclusion is that we need to promote the science of healthcare delivery. And by that I mean more than comparative effectiveness research, we need basically to institutionalize the idea that learning what works and what patients want is a fundamental requirement of everyday science. It's not something special we do at the end of a long development channel just to see whether something works. It has to be brought and institutionalized into our thinking, particularly in the medical schools and medical school training and so forth. And I'll come back to talk a little bit more about that later. Now, all of these 3 points here are points that are going to require change in the delivery system, experiment, time, and really cannot necessarily be predicted as to when the potentials for reducing and improving efficiency really will kick in at a system level. In other words, bending the cost curve with these kind of entities is problematic. Even though, for example, the promoting the organized systems of care, certainly the concept of ACOs is part of that. The concept of medical home is part of that. And there are many pieces in the legislation that would be moving in that direction. However, the fiscal crisis we're in, both the entitlement programs, but also generally speaking of how much money we're spending in healthcare, really can't wait. And so the fourth part of the book was to talk about constraints on undisciplined growth and capacity and spending, bending the cost curve in the vernacular, I think, is what this is about. Things that could be done to accelerate the process of moving towards the longer-term solutions, and perhaps, hopefully, actually stabilizing and moving forward on the cost-saving side. So my talk today is going to be about constraining undisciplined growth, the fourth issue, and I'm going to start and go through each of these, or at least through the chronic disease and the shared the discretionary treatment issues first. Now, one thing that one could do is, and it's been proposed and by many people, is that we could basically encourage consumers, patients, to take a much more active role in the decision process than they've been doing. So it's called the skin in the game theory. And I'm going to make a case that perhaps, if all else fails, and it likely will, that motivating consumers, patients, to participate in the decision process will be enhanced if there are some financial requirements if one is interested in the more expensive option, treatment option. The point here being that there is no necessary requirement on the part of government or public policy to subsidize for discretionary procedures. Okay, let me just begin with some examples of why this particular strategy, or why we need to pay attention to the utilization of discretionary procedures. And I put up here simply a map showing Fort Myers on the left and Miami on the right, to show you that they're at the opposite poles in terms of the utilization rates for knee replacement, a very great, a good example of a discretionary procedure. And if you look more carefully, you'll see that Fort Myers basically has a rate about twice that of Miami. And it's had that rate, incidentally, over a decade. It's not just something that happens, this was 05, it's consistently higher, and it produces many, many more of these procedures. But what is really interesting and important is that evidence-based medicine is not enough to decide what the right rate is. If one does a study in which one looks at a sample of patients, say from Ontario, which the study actually was done, and does evidence-based search for the people that are eligible according to the best criteria of the physicians, that they have the right level of pain and they have the right level of x-ray changes. Those are the patients that to the physician in the traditional role of prescribing treatments would clearly be eligible for and should have the procedure. The issue here, however, is that if one takes the trouble of asking the patient about their preferences, involves the patient actively in the decision process, it turns out in this study only 15% of those that met the evidence-based criteria met the preference-based criteria that should determine the necessity of surgery from a normative perspective. So there are strong reasons why we should be particularly interested in promoting shared decision-making because the consequences is operating on the wrong patient. Patients who, if they had been informed, would not want the procedure. And from this study here, we can say that appears to be about 4 patients out of 5 or even more would be wrong patient surgeries if we simply based it on evidence. So this is an example of the simple implications in terms of cost. If the Fort Myers standard for practice were the national standard, we would have to spend $1.2 billion more than we did spend in 05 to reach that. If the Miami standard, we would save $1.4 billion. So that's the reason why, from the perspective of public policy, we should be very interested in the which rate is right question and driving towards that. Now, this is not just one procedure. It is all of these procedures here in Medicare are similar in terms of variation and similar in terms of the need for getting the patients involved in the decision process. Together, these procedures make up about 25% of Medicare's spending, overall spending. So it's a big ticket item. They are big ticket items taken together and need some attention. Now, one of the important innovations that has happened over the last 15 years is that decision aids have come on the scene, patient decision aids, which are designed to have a balanced representation of the treatment options to inform the patient about the pros and cons or the risks and benefits of those procedures, and to encourage the patient to actively get involved in the decision process so that their choice of treatment will reflect their preferences rather than the opinion of the profession or of evidence-based medicine, if we want to put it that way. And what these decision aids do, this is, by the way, a summary of from the Cochrane collaboration, which summarizes clinical trials into into cohesion or into comprehensive summaries of the literature, these have shown that consistently decisions made with decision aids produce a better decision, and better decision in the specific sense that the patients are more knowledgeable about their options, and secondly, they tend to choose procedures which more will reflect their underlying values, their own preferences, and that they work in a very interestingly way in the clinical trials to show that, generally speaking, the demand for surgery actually drops once the patients understand that they have an option and it's up to them to decide. So that, in a sense, then, is the rationale for introducing decision aids, and why it seems to me quite reasonable that if patients are preferring the more expensive treatment, that there should be some differential copayments or some way, essentially, of drawing the patient in so they have a monetary as well as a preference that doesn't trade off any of the differential costs. Now, my argument here is not that this is necessarily something that we should do tomorrow morning, but it's something that we should definitely keep in our eyes, because if it turns out that costs go up rather than down, or they go in unpredictable ways, this is a treatment. This is an option that should be considered. Now, let me go on to talk about the chronic illness side of the equation. And here I'm particularly interested in discussing with you the idea that of an outlier penalty that would specifically target high-cost hospitals in high-cost regions in managing chronic illness. And the idea here is that if we were able to signal to hospitals that CMS, and I would hope private insurance entities, are no longer willing to pay for utilization no matter how high, that we would see some interesting changes in the behavior of the market. And some of the provisions, for example, the ACO concept, which has a shared savings provision in it, would be accelerated if it were understood that in the long term there would be constraints on the overall budget that we would be willing to pay for inpatient care for chronically ill patients. Now, to get the full story and the full justification for this, you will have to read the book. But I do want to go through the major points of the argument so you can see where we are, where I'm coming from. Now, this chart is unbelievably complicated, but it's pretty quick to get the main point. This is the variation among regions, among the 306 Dartmouth regions, in the amount of money Medicare spent per enrollee in 1905. Or 2005, and this is Florida. It goes from around 7,000 up to 14,000 per person living in the different regions, and you can see similar outlier regions as you go along here. And what is even more interesting is how much it is. We're talking about Miami for chronic illness in the last 2 years of life, spending $72,000 per person. Tallahassee, 37, less than half. And that is the way the world is in terms of spending. And this level of spending, by the way, for these kinds of services takes about 60% of Medicare's budget. So here we're talking about a big chunk of what's at stake in terms of the fiscal situation for Medicare. Now, even more interesting from the point of view of something that could be done about this is it's not that all hospitals within a region are the same. This is the Miami distribution of the individual hospitals. So some hospitals are spending over $110,000 per person in managing chronic illness, and others are down around $60,000. So when I talk about the idea of an outlier penalty, I'm talking about these guys up here. A simple equation that we did was if we were to reduce the highest spending hospitals from the 100th, that are in the 100th to the 98th percentile, just down to the 98th percentile, we would affect only about $150 million in savings. But we would send a broad signal across these markets that utilization per se is no longer going to be paid for without some countervailing force. This, I think, would have an important role in changing the dynamics in the market. This is based in part on what might happen to the bond markets if suddenly it was realized that CMS and the private industry was no longer going to keep paying for utilization indefinitely. This is a report by Moody's that came out in November '09, and it was based on the Dartmouth data and the debate that was going on at that time on health reform, that high-cost urban hospitals might be targeted, or at least high-cost hospitals might be targeted. And what they basically said was that may force them to evaluate and re-rate the bonds. And certainly one of the biggest problems in terms of the growth of the hospital sector has been the availability of very low-cost money because the general perception that there's virtually no risk in these kinds of investments. So Moody's at least thought that if there was signals coming out about health reform that high-spending hospitals were not going to get away with it indefinitely, that this, in fact, could change the market, make it more difficult in high-rate regions to achieve funding and financing, and put some kind of a general brake on it. And so, this is where they took the data right out of the Dartmouth Atlas. So basically, what we can say here is that one strategy for putting a bend on the cost curve would be to figure out how to identifying is not a problem, but how to actually implement some form of constraint on the spending in the highest regions and the highest hospitals. And I have to tell you that these high hospitals that I was signaling here are generally not academic medical centers. They're basically fairly small hospitals that nobody ever heard of until they got signaled here in the Dartmouth Atlas. So we're not talking about a huge constituency that's going to necessarily rise up and say, don't do this. And that'll become evident here in a second when I do look at my third sense of how we can put some brakes on the expansion of the system is that to base our workforce policy, such as we have, on benchmarks from efficient delivery systems. Now, what do I mean by that? I mean basically we're committed through the Medicare program to fund residency programs around the country, and so far there's been no constraint on what is done with that money. It can be done, that you can produce anything that you want, that wants to be produced by the recipients. And not surprising, academic medical centers tend to want to replicate what they most do themselves, so primary care has not had a high priority, especially training has. And the interesting thing is that if one uses benchmarks of efficient delivery systems, and here I'm talking, for example, about the Mayo Clinic or about Intermountain Healthcare or even many of the efficient states and hospital regions, we have more than enough physicians available now to meet any projected demand based on the general assumptions that are made But even more important is the question of how many physicians do we really need? And here again, I think by concentrating on how some of our academic medical centers actually practice medicine, we'll see that there really isn't a science in terms of how many physicians we need. And the lobbying that comes out from one sector is based, and here I'm talking about the academic medical centers, is based on a rather strange kind of general average. Let me show you here. First, the spending levels in the last 2 years of life go all the way from 105,000 at NYU down to 49,000 or 50,000 at the University of Wisconsin, Mayo Clinic, and Cleveland Clinic. Now you'll note that the academic medical centers at the bottom of this distribution have a common characteristic, namely they're organized group practices and have been with a long tradition of being a group practice, whereas the ones at the top do not share that property. But the more important point, at least in this sequence, is how many physicians actually are being used at these places. Now, this data here is a full-time equivalent physician labor input. That's actually how many doctors are, by our estimates, are being used by these institutions in serving people over the last 2 years of life with chronic illness. And it goes all the way from 50 physicians per 1,000 down to 17. Very, very striking differences. And if we took, for example, the benchmarks provided by the Cleveland Clinic and the Mayo Clinic to determine the national workforce policy, we would be producing many fewer physicians than if we took the NYU benchmark. And you'll have to tell me which rate is right. Well, I'll argue that the right rate here in a time of fiscal emergency has to take into account the following slide, which shows you along the horizontal axis the number of physician labor inputs, FTE per thousand. Now this is the entire population. It's not just the 65, not just the last 2 years of life. And here's the amount of money spent in these regions for everything except physician services. In other words, physicians are responsible for most of the spending in the healthcare system, and this shows you what happens as you increase the supply of physicians in terms of Medicare spending. So a simple interpretation of this slide would be that we should look carefully at the subsidies that we're now providing for postgraduate training, and we should pick a conservative strategy rather than one which is on the liberal side. And the liberal side here would guarantee that costs will go up because as we increase the number of physicians per capita, these costs will go up. Now, the question is going to come up immediately about what's the outcome and what is the value gained by having this differential in resource inputs and spending. Unfortunately, because the science of health policy or healthcare delivery is so rudimentary, this question cannot be answered at the patient level. In other words, we don't know, as a result of published studies, whether the way of managing chronic illness at the Mayo Clinic produces better outcomes or worse outcomes than NYU. And why is this? It's because academic medical centers have paid absolutely no attention, nor has the NIH paid any attention to this level, this point of science. And I'm going to argue that it's extremely important for the future of medicine that we, and I've got it in quotes, we regularize the science of healthcare delivery. And by that I mean it in the sort of sense of Thomas Kuhn's use of the word regular science, that we basically need to make the evaluation of medical practice part of the training of doctors, the education of doctors, and we have to have a very strong presence in the NIH and AHRQ in terms of peer-reviewed work that will entice and get academic medical centers to face up to their own practice variations. And at this point in time, they are mostly in a state of denial. They will not recognize that there's even variation. This is not a long-term problem, assuming that science has some role in figuring out what people's belief sets are. But I won't get into the details on that one. But basically, this shows you, again, the impact on populations of the differences in practice patterns of these institutions. And this is the percent of all people who are using these hospitals who die in the intensive care unit. So at NYU and UCLA, more than a third of all deaths are happening in the intensive care unit or shortly thereafter. They may be put back on the regular ward, but they were in the intensive care unit during a terminal admission. And if you go down at University of Wisconsin, is 16%. Very, very different ways of practicing medicine. And the implications are not just in end-of-life care, they're in the whole intensity with which chronically ill patients are treated over the course of their illness. And it also has a tremendous impact on patients. The average co-payments in the last 2 years of life range from $2,000 down here to over $5,000 up here. So it's not just the patient experience of care, but it's also the out-of-pocket costs that are being signaled here. So this whole question about the outcome, still right now, this is where I think we are. We basically have shown through a series of cohort studies that patients who live in high-intensity regions or are treated at high-intensity academic medical centers do not have better outcomes in terms of survival. They're either no better or they're worse. Patient satisfaction seems to be worse. Access perceptions are worse. And objective quality measures are worse. So we find no justification in the data for sustaining this very level of variability among these institutions. But the remedy for this uncertainty is, I believe, at two levels. One is at the level of not allowing continual expansion, doing things to retard that, workforce policy, outlier payment, hopefully the incentives that are associated with the shared savings thing will liberate some of that capital that's tied up in these acute care hospitals in Los Angeles and places like that. Because remember that if you could only bring the expenditures in the high regions down to a reasonable benchmark, you're talking about lots of money being saved, lots of money. And to the extent to which the ACO model actually delivers that savings back towards the managers and the physicians and so forth, you may have huge incentives to move if you just get the ball rolling. That leaves me essentially on time, which is unusual. And I realize I've gone through quite a bit, but I think the basic sort of summary is that for preference-sensitive treatments where there are options, and those options are evidence-based, but they have very different outcomes. Lumpectomy versus mastectomy, if you want another example, joint replacement, silent stone operations, a lot of these procedures that are on the list I showed you. For those, we need to, the standard of practice needs to be changed to inform patient choice. And we need strategies and policies for getting there. I've suggested that co-payments may help. There are other things that could be done, such as changing the malpractice laws to give greater immunity to failure to inform to people who use shared decision-making. And this has already happened in the state of Washington, for example. And it's possible that this will all happen by itself. But I think prodding and pushing, and I do believe that this issue should find a lot of consensus on both sides of the aisle, because who can argue against informed patient choice, and at least persuasively argue against it. For the way we manage chronic illness, our problem is that we have overcapitalized the acute care sector, undercapitalized the community sector, and we don't have organized care that could ever really do anything except episodic treatments for chronically ill patients. The exceptions are places like Intermountain Healthcare, group practices like Kaiser, like Mayo Clinic, and we need policies that push those options. And the ACO option is one out there, and it may work. And I think it has a better chance of working if we couple that with an economic incentive saying that thou shalt not spend more than a ridiculous amount. And we'll pick that ridiculous amount and say beyond that you don't get paid. And that will begin to signal things. Perhaps the bond market will respond in ways that Moody's suggests it might. And perhaps that will get us where we're going. On the other hand, we still need to worry about our workforce policy, and we need to worry about our science policy. And I'm glad that the next speaker is going to worry about our science policy. At least I hope I haven't.
Thank you, Jack. Thanks very much. You've said a number of provocative things that I think is going to lead to some interesting discussion. I forgot to tell Jack, but I'll tell the other two speakers that that because we are webcasting this, if you can stick close to the microphone, people who are listening in on the web or who come later to the website will be able to hear what you have to say. And then when we get questions from the audience, I hope you'll wait till the microphone comes. So our next speaker is Dr. Carolyn Clancy, who is the director of the Agency for Healthcare Research and Quality, a position she's held since 2003. Some of you may know the history of ARC and its near-death experience in the 1990s. But it's held its own since then and has an important role to play in healthcare going forward, improving the quality of care. Dr. Clancy is a general internist and a health services researcher, and she is a member of the Institute of Medicine and a master of the American College of Physicians. In 2009, she was awarded the William B. Graham Prize for Health Services Research. She also serves on the editorial board for a number of medical journals, including a senior associate editorship for the Journal of Health Services Research. Dr. Clancy, thank you for joining us.
Hello, everyone. It's a very, very distinct pleasure for me to be here today in more ways than one. First, I think as many of you are aware, Jack's work was directly instrumental in the creation of the Agency for Healthcare Research and Quality, or ARC. So without him, I might not even be here with you. In Washington, we have policies, and success has thousands of parents. But in this case, you can draw a very, very clear line. The seed for ARC, or what became ARC, was planted in 1984 by a special issue on practice variations that was published by Health Affairs. So Jack was one of the speakers at a news conference announcing the issue that was held at the Capitol. And in the years following that news conference, Jack spent countless hours urging lawmakers to fund variations research. And the initial idea was to include an amendment in the legislation for the National Center for Health Services Research. And Jack, I do believe Senator Proxmire's idea was somewhere in the ballpark of 1% of what Medicare was, 0.5% of what Medicare was spending, which would have taken a very small Center for Health Services Research and made it quite humongous. However, that idea ultimately came to fruition in what was a much more ambitious bill, and frankly, supported by a group of policymakers who came to understand the importance of this work, that was passed in 1989 to create what was then called the Agency for Healthcare Policy and Research, or ACPR, as we shortened it, and would later become ARC. Now, I first learned about Jack's work in 1985, a year after the news conference at the Capitol. I was on the faculty in internal medicine at the Medical College of Virginia, and I was interviewing internship applicants. So I got very involved in a conversation with one of them, a medical student named Ross Jaffe, about my interest in medical decision-making, and he asked me if I knew about Jack Wennberg's research. He had been working with Jack, and I do believe is a close friend to this day. And based on this conversation, he was just very energetic and a very thoughtful guy. I decided to attend a conference up at Dartmouth. So I got in my car and I drove up from Richmond, Virginia to Lebanon, New Hampshire. And this was the first conference I'd ever been to where a researcher had brought together local physicians, medical society members, and others directly providing care. And what was also clear in retrospect was this wasn't the first time they'd gotten together. None of the, there was a certain level of formality that just was absent because they'd had meetings before. And Jack wasn't lecturing them about how his work could help them. Do this and you'll give better care. He was actually engaging them in a discussion. He would say, when we look at the data across the state, here's what we see. And he didn't point fingers at them. He'd say, what do you think? And he clearly had a huge amount of respect for people who provide care every day, and he intuitively grasped that much of what we see in practice variation is a very clear indication of a lack of evidence. He also grasped that for the most part, and I think people still may struggle with this a little bit, doctors are flying blind. They actually can't tell you how they've done for the last 10 patients who had this surgery or that they're providing care for with diabetes or fill in the blank, unless they've got a system to help them do that. Now, we're starting to build those systems, but in 1985, no idea whatsoever. So I was just totally sold. So I would say that Jack's work pretty much provided the blueprint for creating ARC. And you can also draw a very direct line from his early work in what we now call comparative effectiveness or patient-centered outcomes research. Today, this research, as it has been conducted by ARC since our explicit authorization in the Medicare Modernization Act in 2003, is front and center in many current efforts to transform the nation's healthcare delivery system. And it very much includes the science of healthcare delivery. The research was a focal point in the Recovery Act, a total of $1.1 billion invested at HHS, which was incredibly exciting, and many people working incredibly hard right now. And two of the major inputs to that, how to invest that $1.1 billion, the Institute of Medicine study for setting priorities, and a completely independent federal coordinating council for comparative effectiveness research, which doesn't exist anymore. It went out of business the day the Affordable Care Act was signed into law, independently came to the conclusion that we couldn't just look at what works for which patients in clinical interventions, but we actually had to be thinking about what I'm going to call care improvement strategies in quotes, because our vocabulary and taxonomy and how we even think about these interventions is not nearly as well developed. So after an amazingly busy year, and it's really appreciative of the fabulous team of people I get to work with, ARC announced that we had invested just under half, or $473 million, in grants and contracts for projects to support patient-centered outcomes research. And I'm really proud to say that they touch on a lot of the themes that Jack just so very clearly articulated. So there are patient-centered research studies in healthcare delivery, which when Don Berwick heard about these for the Innovation Center, he wanted to know, I need a summary, I need to know everything you know right now about healthcare interventions in real-world studies, advancing the use of research findings by diverse populations, development of registries, and training and career development for the next generation of researchers. The real game-changing aspects of this research that I would really underscore, and you clearly heard that today, and it's all over the book, are the research that actually follows patients over time. It's astonishing how little information we have. And research that incorporates patients' outcomes. Obviously, living or dying is probably the penultimate outcome. But for many people with chronic illnesses, the usual physiologic metrics that we use, lab tests, blood pressures, that kind of thing, actually are completely meaningless, right? For people with chronic lung disease, for example, their numbers are always horrible. The only way you can know if you're doing more harm than good is to ask the patient in front of you. And thankfully, really, as a direct result of Jack's advocacy and his ability to communicate this very clearly, not always co-resident with scientific skills, that communication skill. This has become more and more commonplace. There's been a huge amount of investment. Now, the Affordable Care Act builds on that by creating this new Patient-Centered Outcomes Research Institute. This is an independent private sector institute that will set priorities and coordinate with existing agencies that support patient-centered outcomes research. So that would be ARC, it's VA, it's a lot of private sector entities, it's the National Institutes of Health, and so forth. A direct allocation of that budget will come to ARC to support dissemination. How do you actually hardwire this into the delivery of the fabric of care every day, and to train researchers and build capacity for this research. The Affordable Care Act also directs the Secretary to create a national strategy for quality, which the great hope here is that it will begin to align what the public sector and the private sector investments are doing, whether that's rewarding better quality of care through financial incentives, providing technical assistance, and so forth. And that report should be out shortly, and it in turn is intended to inform the priorities set by the patient-centered outcomes research. So one of the greatest benefits of expanding the use of this kind of work, patient-centered outcomes research, is that we'll also learn a lot more about where the gaps are. We simply don't know very much about the gaps. So for example, if one of you on paper met all the criteria to be eligible for a new breakthrough treatment and it didn't work for you, you and your physician and team of health professionals would try to figure out what else you might do. But the signal that it didn't work, that there was something wrong in this script, would never actually directly get back to the basic biomedical enterprise. It might through some letter to the editor or informal networking, but it certainly wouldn't be an expeditious signal. And there's a number of other provisions in the Affordable Care Act. I would assert to you that the quality provisions broadly defined in this bill have been vastly underreported, partly because it's complicated to try to figure out, and partly because there's so many of them. But there is one, Section 936, which is intended to facilitate shared decision-making with goals that include encouraging discussions between patients and healthcare professionals about treatment options and incorporating patient preferences and values. I mean, Jack was there 25 years ago, and we're catching up. But so if this provision ever gets funded, we could really go a long, long way. There's also a very exciting demonstration in place right now that actually came out of the Medicare Modernization Act, or the drug bill, in 2003. This actually is a direct product of a paper written by Jack and his colleagues that got the attention of Senator Jeffords in 2001. The demonstrations are now ongoing in North Carolina and Indiana. And essentially what these demonstrations are trying to do is to almost build a, I'll call it Mayo-like sort of enterprise where there's a lot more flexibility that ultimately allows providers to ask the question, what does the patient need, rather than what can we bill for? That's putting it perhaps a little bit too baldly, but I think it's a very, very exciting prospect. So I would just say that Jack is really the lion in health services research. One question, because this is a multidisciplinary field and sometimes hard to explain, and when I'm out with my husband and people ask me what I do, my husband always gives me this really rapid look that says, no details, please. But sometimes, to make this simple, people will say, okay, who would be the Nobel Prize winner in this field? And to a person, the first answer is always Jack Wennberg. So today, few, if any, people argue against the idea that unnecessary variations exist in healthcare. The Dartmouth Atlas and, greater interactions with the internet and so forth have made this a very commonplace understanding. And I have to say, Jack, when I testified with Peter Orszag in 2007, and for those of you who've never presented at the U.S. Capitol, I'll tell you that audiovisual equipment is not there's not a lot of it. And in fact, sometimes when they tell you there will be AV equipment, it actually isn't there at all. So you've always got both talking points as well as slides or whatever. But he walked in and he used 2 of your slides from the Atlas. And to see the whole Ways and Means Committee completely mesmerized was quite an experience. So his latest book combines the science with practical experience in a way that humanizes research. And as we move forward with all of the concrete problem solving involved in system transformation, I can only hope for all of us that Jack's influence on what U.S. healthcare looks like coming out of this period will continue to grow. Thank you.
Thank you, Dr. Clancy. That was terrific. It fills me with fear and hope at the same time that we might be able to be able to extract some real meaning out of better data and better information. So our last speaker is Representative Jim Cooper from Tennessee, and this is a position that he's held since 2003. Jim is a Blue Dog Democrat, which I think means that he pays attention to cost as well as to social issues, which is a hard line to follow, I think a hard line to walk. Congressman Cooper has built his reputation around independence and a commitment to bipartisan solutions. He's a graduate of the University of North Carolina and Harvard Medical School. He's worked as both a small business owner and as an attorney, and he teaches healthcare policy to MBA students at Vanderbilt's Owens School of Management. He's a member of the Armed Services Committee and the Oversight and Government Reform Committees, and he's also one of the smartest people up on Capitol Hill on the issue of healthcare reform. So we're very pleased to have you. Thank you.
Thank you, Shannon. I'm delighted to be here. I think that everybody who's here today is fortunate to be here because we are in the presence of Dr. Wennberg. Let me correct one thing. I didn't go to Harvard Medical School. I only went to the law school. So I don't want anybody to think that I'm a doctor, although the power of the white coat is amazing. Dr. Wennberg is a giant. Many of you in this room will be telling your grandchildren that you attended one of his talks. You should buy his book and get him to sign it, because it will be the equivalent of having Einstein sign the book. Now, his presentation was modest. It wasn't flashy. It seemed pretty simple. It is not. It is revolutionary. Most of America still can't handle what Jack Wennberg started thinking up 20, 30, 40 years ago. So as you take his ideas and think about them, shared decision making sounds obvious. What families do around the kitchen table, right? Well, it's a lot harder than that in medicine. You know, for many generations, people thought, well, we need a doctor or healthcare worker in the family so we know what's going on, help us navigate the system. And that was family use of anecdotal evidence to try to survive. But it's not very good. Former President Bill Clinton, when he needed a heart operation, actually chose the wrong hospital because he didn't know as a former president. None of us know. We are starved for information. The Dartmouth work, Jack Wennberg's work, good folks like Elliot Fisher and others who've joined the effort, are helping take a doctrine that is ancient in the law, informed consent, but it really is so limited as to be of little use to a patient. It's more a way of protecting a doctor from liability. Shared decision making, as simple as it sounds, is a fundamentally different approach. It reduces the paternalism of the medical profession. It allows their expertise to be used, but it empowers the patient to be not quite an equal partner, but a partner. Because after all, it's the patient's health that is at stake. The data. I'm glad they transfixed the Ways and Means Committee. The Ways and Means Committee needs transfixing every now and then. But the medical establishment needs transfixing too. And for the same pre-med student to go to the same medical school and sit right next to the same classmate and then go out in the wide world and practice a completely different kind of medicine without any rhyme or reason, without any scientific basis, is astonishing. So when Dr. Wennberg calls for studying the science of health delivery, whoa, is that long overdue? We do not know why certain remarkable systems in this country, like Cleveland Clinic or Mayo or Geisinger or Scott and White, or as Philip Longman has pointed out, the VA system, why can't they grow? That marginal doctor, that marginal hospital right next to one of these amazing enterprises, why don't they say, me too? It's working over there. I want to be part of that. We don't know the answers to those questions. We do know that it takes almost 17 years in this country to take a lab discovery and get it out in the field. 17 years. Thousands of other things happen, but it takes hard data. And it's not easy to get hard data from folks who really don't like transparency and clarity and quality measures, because it's like the Lake Wobegon effect. We're all above average. Only we're not. And Dr. Wennberg helps us see that. Now, I'm sure his data is not perfect. No data are perfect, but this has started us on the road to getting, finally, at long last, quality information. Astonishing articles, like Atul Gawande's McAllen, Texas article, The Cost Conundrum, that appeared in the New Yorker and that President Obama said was one of the most influential things written, based on Dartmouth data. Shannon Brownlee's remarkable book, Overtreated, which puts the cookies on a low shelf. You still need to get tracking medicine, but if you really want to popularize the cause, read Shannon's book. I compared it one time. I embarrassed her in an introduction and said, look, this lady is the Harriet Beecher Stowe of our time. You know, Abraham Lincoln said that book started the Civil War. We don't want any wars to start, but we do need a civil discussion on how to change our medical system. Carolyn Clancy, or in the introduction to her, there was mention of an unpleasantness in the 90s having to do with her predecessor agency. That's when a certain category of surgeons in this country couldn't handle the truth and rose up, nearly abolished the agency. That's how revolutionary and in some circles dangerous these ideas are. When all we're talking about is science and clarity and transparency, and if you got better data, show me. So I'm honored always to be in Jack Wennberg's presence. He does deserve the Nobel Prize. I wish they had a category for this, and maybe the Nobel needs to be expanded to include it. But every once in a while, there are unsung heroes that you've never heard of. One that I recently encountered, maybe y'all knew about him for a long time, was a guy named Maurice Hilleman. He is supposed to have saved more lives in the 20th century than any other scientist. 30 million lives, because he invented some 30 vaccines, mumps, measles, all sorts of stuff. Jack hadn't done that, but he's used the left and right-hand side of his brain to figure out the care and the numbers to help us find new ways to save lives in all corners of our country. So it's a real privilege to be in his presence, and I look forward to being on the panel with him. Thanks.
Thank you, Jim. Gosh, we've heard a lot of provocative statements, interesting statements. Ask the patient. There's an interesting idea. Doctors are flying blind. That shocked me. I remember, Dr. Clancy, when I started to figure that out as a medical writer, that an enormous amount of what was going on in medicine was not based on what I had always assumed it was based on, which is valid science. The idea of giving patients skin in the game for expensive elective procedures. The idea that we need to squeeze the hospitals that are at the top of the spending charts. So we've heard quite a few things. I'm going to throw out the first question, and then I'm going to ask all of you to come and get the microphone and ask questions. But I'd like to ask Dr. Wennberg the question that Representative Cooper asked, which is, why can't the great places grow? Why can't the Mayos and the Kaisers and the Geisingers and the Intermountain Healthcare, why are they not growing?
That's a very good question. For one thing, most of these organizations are not for profit, so access to capital and the idea of growing a business is not in the ethics of these organizations. Kaiser does grow, by the way, slowly, but it does. It's had some interesting growth in Georgia, where they actually have departed from their fully their full capitation model to hire family practitioners who have gone in and become Kaiser docs in places where they've had to deal with the local specialists. And that was forced on them mainly by the insurance or the employers who said, we'd like to deal with you, but we have a plant in different parts of Georgia and we need you there. So there are some incentives that'll work. The ACO model could work for these places. One of the things I do discuss in the book is Geisinger Clinic bought a couple of hospitals in Wilkes-Barre and closed one of them because it turned out to be fairly inefficient. At least they closed all the medical beds. And had they been in a shared savings program like it's designed, they would have made a lot of money. I think we calculated about $12 million just because that's the amount of money that was sunk in that particular piece of real estate. So there are some incentives out there to do that. But again, when you're focused on your own population of patients, you may not want to take on new burdens, and so there's got to be some incentives out there.
I'm going to throw it open to questions. I'm going to go ahead. Do we have just one mic?
Just one.
Okay.
Sure. I'm Dr. Carolyn Poplin. I'm a primary care physician. I've been a big fan of Dr. Wennberg, especially early on when he did the pairs of cities and the tonsillectomies and the hysterectomies and all that. The line from that research to an ACO isn't entirely clear to me. The Cleveland Clinic and the Mayo Clinic do wonderful things. I have worked at Kaiser and for the military, which is another kind of ACO. And there is a dark side to the ACO as well as a bright side, especially if you are a primary care provider at the bottom. But my question is actually different. It is, in Europe, they've managed to provide better care at half the cost for all their populations without ACOs. They have, as far as I understand, conventional delivery systems with a different kind of electronic record. Why do we have to reinvent things? Why don't we look to see what's already worked for a lot of other people?
I take it that's my question. You know, I think the underlying principle is that we, particularly for managing chronically ill patients, we have to have teamwork, and to do that we have to be organized, which means that the patients need to be followed, and there has to be some way that we treat them so we don't keep referring from one doctor who takes care for a while, then refers back and so forth. And an awful lot of the high-cost regions, the correlations that we consistently see are places that have multiple doctors taking care of a given patient don't do as well on quality measures, and they cost a lot more. So I don't have a particular sort of point of view about the ACOs, other than that it is an attempt to get some organization, and it may not be a good idea in some cases. Certainly if the hospitals take over and the poor primary care physicians are at the bottom of the heap, that would be unfortunate. And maybe perhaps a medical home model would work better, and it's out there. But I think the one underlying principle is that we need to become organized in places where we aren't organized, and that could follow many different models. But the general principle is that we need to be accountable for care over time. And in the case of shared decision making, we need to be accountable for informed patient choices. Primary care could do a lot to take both of those burdens on themselves, and that would be a great step forward.
I'd like to ask a question of Congressman Cooper. Is what do you think the chances are that we would see some kind of funding for shared decision making? I mean, it was great that it was in the bill, that there's this support for it, but what are the chances that we're going to see any kind of real funding for it? And isn't it something that goes across the aisle?
It is something that it's bipartisan. It's also something that's barely understood. That's why think tanks like this need to help popularize the concept so that regular voters come to their congressman and say, hey, I want shared decision making, so that the bar understands this concept. You know, this is a fundamental rethinking of the entire system. It's patients' rights. And a lot of folks are really not too fond of patients' rights. The consumer revolution has barely entered medicine. So this is how bold Dr. Wennberg's thinking is, and I think it's a necessary change, but we're still in the earliest stages of it. It will take years for this to work its way through the system.
Mm-hmm. Go ahead, Sam. Why don't you just make sure the next person already has the mic, and then we can go from there. Thanks.
I'm Anthony Odie. I'm a consultant on economic policy. I wanted to give Dr. Wennberg just a chance to push aside a possible objection which many people might have to the data. We're implicitly assuming that the different units in the comparison are seeing roughly comparable patients. I might say to you, yes, but in Tallahassee, we send the difficult cases to Miami. Mm-hmm. And that's, that explains this. Mm-hmm. I'm sure you've got wonderful answers, but could you just walk us through them?
Right. Well, I think that the question here is whether illness explains the differences. And the models that we use, for example, Tallahassee patients are by place of residence, not by where they got their care. So if they went to Miami, it would not count for Miami, it would count for Tallahassee. So that's the general strategy of the model. But the other thing is that by concentrating, as we sometimes do, on the last 2 years of life, there's an implicit standardization there for illness, in the sense that everyone at the end has the same outcome. They're all dead. And so far, we haven't got too many arguments that my people are deader than yours. but we do get arguments that the dead people in one region are dying from something differently than they are in the other region. And the way that we've been accounting for that is by standardizing according to diagnosis. So that's about what we've done. I might just say parenthetically that we've been doing quite a bit of research recently that is just beginning to get published, showing that the standard methods of risk adjustment are problematic because of over-adjusting for regions that have lots of doctors, therefore lots of diagnoses. So there's a supplier-induced diagnosis problem as well as a supplier-induced treatment problem.
Yes, I'm Paul London. I'm also an economist, and I do some consulting. Over the years, I've done a lot of work in other industries and some in healthcare. What I think is remarkable about discussions about healthcare is that there is very little discussion of how markets work in other industries, or how other industries work and reform and actually get lower prices over time. I think when you look at the charts that Dr. Wennberg put up, you see that there are no markets in healthcare, even local markets. In any other industry, these high cost providers would be put out of business by somebody coming in and offering comparable care at a lower price. In healthcare, it doesn't even work that way on K Street. There is no real competition between doctors. And part of it is we don't have computerized records. We don't know what different people care or how different people operate, different doctors. But it has always seemed remarkable to me that the insurance companies don't do more to steer patients toward good providers who charge less. I mean, I know that Walmart, for example, is sending a lot of its patients now to Mayo because they think there's better care at Mayo at a more reasonable price. But very few insurance companies or businesses that insure their employees seem to do that. And I think that's the answer to your question, Dr. Brownlee. You know, there's just no unified market, if you want to use that term, in healthcare. There's no national market, not even a local one.
I'm not sure. I'd like all three of you actually to sort of think about this one and answer it, because I think there are layers and layers and layers of questions here, and one layer has to do with how would patients know who's a good doctor and who isn't. But beyond that, how would patients know what's a good treatment and what isn't, and which treatment is right for them?
Well, the first paper on this was Kenneth Arrow in the 50s when I was born. You know, other economists have weighed in. It's obvious it's a dysfunctional or non-functioning market. But there's so much money to be made in the niches of a non-functioning market. And the folks who have market power are unwilling to let it go. And that includes even some virtuous-looking people in the system because they know no better. Keynes once said that we're all the slaves of some defunct economist. And we're all the slaves of a broken health system. And it's about time that smart economists and other help us fix it.
So I would say that for many diagnoses and many people finding out they have something new, they basically have two questions. One is, what should I do? And the second is, where should I go? The what should I do or what are the options piece, I think, is easier. And, you know, the Pew Foundation and others are constantly coming out with statistics with more and more people being online for some kinds of information. The where should I go part is hard. I think that will get better. There's clearly a lot of provisions in the Affordable Care Act encouraging, requiring more transparency about quality and so forth. But Jack at one point used the word beliefs. You know, a lot of medicine has to do with trust and how well you can communicate with this person who's making recommendations and so forth. And so shared decision-making for some people is almost like a super patient using his or her physicians as expert consultants, subject matter experts. But basically they're making all the decisions. For others, the question is, what would you recommend for your mom? And, you know, I think a lot of other people who are busy searching online are struggling with that. Today there is not real good information available about docs, so I sometimes say it's a little bit like marriage. This ought to be, particularly for primary care, someone that you can work with and communicate with, so that if you've got questions and this person's out the door before you've actually finished asking the question, not a good thing. If you can't get your phone calls answered and so forth, that's a challenge. But I'm also looking at some papers that are coming out in press in the near future, at least two different countries, the U.S. and one other one, looking at if you give people information about quality ratings of doctors and financial incentives to choose better ones, it's really quite remarkable how people don't yet trust all of the quality ratings, especially if they're not transparent. And you can overcome the financial incentives to quite a strong degree if they get different reports from friends and family members, people they trust, or from their primary care doc. So, you know, this is a fairly complicated puzzle. I think that we can get there. I certainly know every time there's open season for federal employees, my phone rings off the hook and emails and so forth. I need a doctor. I need a primary care doctor who takes insurance in this area is one I get a lot.
I just might comment that one of the problems with the market is that the actuarial base for insurance is so diffuse and so non-localized that there's no strong signals coming back to residents of Miami that they're spending at the level they are. Transfer payments are coming nationally through Medicare. Medicaid's state-rated. Teachers union is state-rated. IBM, major corporations may have the whole national point. So one of the fixes that I didn't discuss today that we suggested was that if you really were getting serious about creating markets, you should create markets should be associated somehow with the regional systems that are in place. So your actuarial ratings in Miami would reflect local costs. How to do that's another big problem, but that's just one issue, and it's caused a lot of friction. Just talked about it in terms of Medicare. It led to the IOM, I think, doing a big study on it, didn't it? Mm-hmm. People trying to fix these transfer payments. The other piece of the puzzle that I believe should be considered, Jim, is trying to move the country towards an all-payer system so that we have claims information not just on Medicare but for everyone. Again, in the name of transparency, it seems to me that's something that would be reasonable to ask both sides of the aisle to support.
8 states have all-payer already, and more
Right.
should have them.
Can I just add
Yes, please.
one other aspect of this I think that we forget in terms of thinking about markets and actuarial values is that the distribution of health expenditures is not remotely linear. In theory, the variation in need for, say, a cell phone or fill in the blank for a consumer electronic or something, the variation there is not so vast. The willingness to pay might vary, and the perceived need for having 4G and all that kind of stuff is one thing. But healthcare expenditures are pretty skewed. So in med school, you learn that 20% of people get 80% of the diseases, and it turns out that 20% of people in the Medicare population are associated with about 72% of expenditures. So every time, this is straightforward, health statistics or expenditure statistics, but I think it gets lost in a lot of back and forth about whether Americans pay enough or too much and so forth out of pocket, in particular whether they don't have enough skin in the game or maybe they have limbs in the game, because it just is not randomly distributed. So that's always part of the puzzle here as well.
So in other words, what you're saying is that what you're all three saying, I think, is that there's this enormous transfer of money in Medicare at least, from taxpayers in Iowa to Medicare beneficiaries in places like Miami. Yet that's not made transparent. Then there's no transparency really in the quality of the hospital that you might go to in your local area, or the quality of the physician that you might choose in your local area either. So there's these large opaquenesses, and then there's local opaqueness as well.
Yeah, we tried to make the local distribution transparent. How much money each hospital was getting, and whether or not what the co-payments were. So it is possible to get some data out there, and I think that information really could become actionable if people really wanted to do something about it, both in terms of personal choices about end-of-life care. You saw the big differences between hospitals, and also in terms of policy issues with regard to whether or not there would be some kind of outlier payments.
Next question. All right.
Yes, my name is Jim McGee, and I am not an economist. Before I go to my question, I'd like to address a comment by Dr. Clancy with a little story. I used to work for the Pennsylvania Healthcare Cost Containment Council. We were one of the first to do outcomes. And we did a focus group in a town that had 2 hospitals. And we were basically asking the people there, I posed the question, you have 2 hospitals, one's a religious hospital, one's not a religious hospital. If we can show you that the non-religious hospital has better outcomes at lower cost, would you agree to a benefit plan that steered your people in that direction? And you know what the response I got was? I know if I die in that religious hospital, I'll go to heaven.
Wow. Sounds like my family.
But I administer
Doctors
one of the
really
larger
are
benefit
priests.
plans in this town. And I would like to know, and I'm not sure who can best address this question, how you reconcile notions of an integrated delivery system with an incredibly fragmented system of portals of access into that delivery system. I've been, unfortunately or fortunately, associated with the employee benefit field for all my career, and I finally come to the conclusion that this employment-based healthcare system just does not work.
Anybody?
Well, the healthcare reform bill allows people, especially small businesses at first, to move away from an employer-based system. But it's a compromise. The president promised that you can keep what you got. And most large risk pools are actuarially sound and can possibly deliver a good job if the HR manager is really on top of his or her game. But for small businesses, it hasn't ever worked. And the bill is an acknowledgement that there are better ways for small business to be served.
So I think one of the problems is not portals of access. If you would want a responsive system, I'll put that in quotes, to have many portals of access, whether you have a question that's driving you crazy at 8 o'clock on Sunday night or whatever, or you are having an acute problem or you need follow-up for chronic illness. Yes. I think the bigger challenge is just the power of information. And the problem isn't that people have too many places to enter. It's that when they go to another place, they have absolutely no idea what transpired over here. I learned about this as a medical intern when I saw a woman who didn't speak English and came in with abdominal pain, and I booked her for a test, and I asked her in every way I knew how. She had a friend who was interpreting, not terribly well, it turned out, if she took Mylanta. And she went home to come back for tests, and I got a lab result that was off the wall. So I actually went to her house. She didn't have a phone. There were bottles of Mylanta everywhere. And, you know, the point of that story isn't about what language you speak, but it's more about what information you don't have. When docs have information, and they feel like they're not going to be threatened by it, they're really, really excited. The surgeons who participate in the National Surgical Quality Improvement Program, this is something started at VA, that ARC gave the College of Surgeons a grant to expand to about 300 civilian hospitals. You can't stop them, right? Some of them are now trying to guarantee safe surgery across the state of Washington. So I think it's more the issue of what information you have. Our real problem is not too many portals, it's that each portal acts like a separate independent establishment that has nothing to do with the rest.
A doctor at Johns Hopkins once told me that being a patient there was sort of like going to the mall. One store doesn't know what you've bought in the other stores, and one department doesn't know what's happened to you in the other departments of the same hospital.
But at the mall, at least you have to carry your bags
At least
around.
at the mall, you know what you've purchased.
Hi, I'm Merrill Guzner with the Fiscal Times. I want to address a question that has to do with the power, really, of the relationship between the physician and the patient, how effective informed patient decision-making can be, or having skin in the game. The text is just simply a suite of articles that appears just today in the Archives of Internal Medicine dealing with dialysis, a $25 billion a year program. For 30 years, we've had an alternative to hemodialysis. We've had peritoneal dialysis, which can be done in the home, costs about 20% less, and has similar outcomes and higher patient satisfaction. Over the last 10 years or so, according to these studies that just appeared today, the amount of counseling that's gone on to patients has gone up, and the amount of people on peritoneal dialysis has gone down from about 15% of patients down to about 5%. Will more skin in the game, will the unequal relationship between doctor and patient have any real impact in that kind of scenario?
I see that as a reimbursement issue. You know that the kidney is the federal government's favorite organ. It has been since 1972. It has its own endowment program. And if you get reimbursement right, treatment will change. There are lots of things that could and should be done. MedPAC has been on top of this issue for years. A lot of folks who care about human beings need to focus on this, because the Wall Street Journal had an amazing cover story just a few years ago pointing out that some 20+% of dialysis patients choose to die basically by constipation. The treatment and is so unpleasant. So this is a very tough condition, and we're spending all kinds of money on it, and we're not getting the results that are available in other nations.
I guess I would just also underscore that the demonstration I mentioned that's now ongoing in Indiana and North Carolina, inspired by Jack's paper, essentially creates some of that flexibility. It does not include, I believe, shared savings, but it does allow some flexibility where, again, you step back from this question of which one reimburses better and what's the right thing to do for this patient based on their preferences and values.
Question?
Hi, Jack Lewin from the American College of Cardiology. Good to see three good friends, and appreciate your comments today. We're very much into moving toward payment reforms and moving toward value-based reimbursements and exploring accountable care. Worried a little bit about whether physicians are positioned well to be part of the governance of those structures going forward. My question today really is about maybe other things we could be considering in parallel at the same time to advance some of the causes we've talked about today. We recently put out our data in veritably all the hospitals that take Medicare for implantable defibrillators to show the fact that 22% of them nationwide are not following the scientific standards we've also put out. So in trying to get in the opportunity with, say, angioplasty stents versus bypass surgery versus medical therapy, where there's a great deal of science and where shared decision-making would be hugely important, we have a heck of a time trying to get pilots to move across the hospitals, even though we have data in veritably all of them. So I wonder if there's any other ideas that could come forward that Medicare, CMS could be exploring now to help diffuse some of those things as we prepare over the next few years for things like accountable care organizations. It seems like there are many opportunities that we could begin already. I guess what I'm trying to say is we can't get anybody to fund these kinds of additional projects, even though we're collecting the data in the hospitals and we have it available to us right now.
Can I ask you, Jack, just a real quick question? Are you saying that the shared decision making should be hospital based, or are you not making that assumption?
Well, in the case of say looking at revascularization, bypass,
the cath lab, and
the patient needs to be briefed about what the options are before they get all the way to the point of a cardiac catheterization at the end of that process. We know that they need to know ahead of time. There are three basic pathways, and there's a lot of science. And after the workup, we're going to try to advise you. Patient clearly needs to be part of the process. But if they don't hear about that first, they're going to expect to get either a procedure or a stent in many instances. So we need to get some things going there, and looking at, say, hospitals. Just look at the UC system in California. The variation for these procedures is amazing. It appears a huge opportunity, but getting a little bit of funding and research to get going on that kind of project has been daunting. CMS got us going with ICDs by requiring the use of the registry as a coverage with evidence development. Any thoughts about how we could expand some of those kinds of things now to kind of set the stage for some of this kind of work and reducing variation later?
So, Jack, we're funding some of this now, including, I believe, some support for the registry you just mentioned, and I thought it was terrific that you got that out. And I think that the other work that the college did, which is really important, was actually taking a very important self-examination of guidelines and quality measures and looking at what's the evidence base and finding that it's not so great. I mean, I think that alone is kind of a motivation and inspiration for the Patient-Centered Outcomes Research Institute for work we're doing at ARC for some of what is going on at NIH. I think there's a huge amount of work that can be done to try to make some of this operational. I think the challenge with shared decision-making isn't necessarily that people don't want to do it. I don't think that we yet have a very good blueprint for how this works, or sort of a mind model, if you will. So just to give you an example from your field, from your members' field, a couple of close colleagues of mine in the past year have, gone for a stress test and, the next predictable things. And, of course, I get a call about an hour before they go to the OR. Now, what transpires does not sound like or feel like shared decision-making to me. I'm not real clear that they knew that whole path. It's very easy to be critical of that. The real question is, how should that have gone? What would it look like? Is this the primary care doc having this conversation? do the primary care and cardiologists get together to do that? I'm not sure what the right answer is, and that may all need to be sort of customized locally. It's a different kind of thing if there's one primary care doc for every 10 cardiologists as opposed to the reverse in a particular area. What I do know is at Dartmouth, not a shock, one of the most exciting projects we funded back in the 90s was actually a collaborative effort across hospitals in northern New England to improve cardiovascular surgery, and they were able to show that they reduced mortality rates. And out of that has grown, they've continued to collect data both for people who have surgery and people who don't, so that when patients come in, they can actually see what it looks like. Ultimately, we all want to know what happens to people like me sitting right at this decision point. If I go this way, what's it look like? If I go that way, and so forth. And I think that we need to build out, I think, see it very much as complementary to these innovative models of delivery.
Jack, would you?
Well, I just think that what Jack is raising here is terribly important, that we have a robust library of experiments in how to implement shared decision-making. The Foundation for Informed Medical Decision-Making will fund and has funded some of these experiments, and some of them have been extraordinarily interesting, like Group Health in Seattle now has fully implemented shared decision-making across lots of things, and it might be interesting to look at how they did this one. But I hope that medical effectiveness research would fund this. It's really important because at some point in time in the future, I believe it's going to become impossible not to adopt shared decision-making because it's an ethical argument. It's not an economic argument. And the Washington State Legislature already has taken this idea and said basically, we will give physicians who use shared decision-making and decision aids greater immunity against malpractice suits than those who just use ordinary informed consent. And I think as Congressman Cooper was talking about, we're going to need to reform our laws in terms of informed consent, and that will be another whole force moving us towards fuller implementation.
I just wanted to let you know, Congressman had to go off for a vote. We're sorry to lose him. Next question, and thank you very much for that. The shared decision-making issue is so incredibly important, and I'm glad you raised it.
Josh Gordon with the Concord Coalition. I guess you read a lot about where these delivery system reforms will take us, and there's either a concern or maybe not a concern that it leads to the hospital being the center where doctors either become employees of the hospital or the hospital becomes the primary organizing factor behind all of these new delivery system changes. And I guess, is there a health care reason for us to not want that to happen? Does it not really matter in terms of health where it's centered as long as it becomes more efficient? And I guess the other thing is I would have maybe asked Congressman Cooper whether that's good politically or bad politically, whether the political will is there to center around the hospital or whether that would get more pushback based on the relative influence of the two constituencies, physicians on their own versus hospital organization.
So, in the simplest terms, I can say that the one thing I do know very clearly is that providing superb care efficiently is a team sport. And so I think the question you're raising is the one that Jack Lewin articulated a moment ago, which is what does the governance structure of these new delivery models look like? And how do people together create a sort of different path than, how do hospitals begin to think about their responsibilities don't end when the patient gets to the front door, met by family and the car comes and so forth, versus one that extends to a place where there's some shared kind of accountability with community partners. We don't actually know what that looks like at all. So I think we're going to have to try to figure it out. And my guess is that healthcare is such a local, regional phenomenon that the answer to what it looks like is going to look quite different. So from a policy perspective, the question is how do you craft some minimum expectations while giving people enough flexibility to adapt locally in such a way that the private and public sectors can collaborate and so forth.
Yeah, I would argue that if you look at this at the systems level, that the major problem of inefficiency in the U.S. healthcare system is that we've overbuilt the acute care sector, and that's probably so in even the more efficient communities. I say that because there are other models that show extraordinary low use of inpatient care if you have a really well organized community system. For example, in my book, I talk a little bit about a retirement home in Hanover that has been self-contained for 15 years, and its utilization rates of the Dartmouth Hitchcock Hospital are the lowest I've seen anywhere. I mean, off the chart. Like only 5% of deaths occur in hospital there, and so and that is a primary care driven model. So if we're looking for a future that creates systems that both patients like, and I can tell you there's a lot of evidence that this particular system is very much liked by the patients. That's what they wanted. We have and we have the wherewithal to transfer resources on a model of care that favors community care when it's feasible and possible. That we don't want to lock into the capital structure of the hospital as being the dominant voice in how we perform. So I think there is a concern there, and one that is different in some places around the country than others because of the uneven spread of the acute care hospital sector.
So I'm going to let one more question, and then I want to leave a little bit of time for those who want to get a copy of their book signed.
Thank you. Is this on? My name is Annabelle Fisher. I'm a professionally trained clinician who has worked in healthcare and mental health, be that at Mass General, at Harborview Medical Center, San Francisco General, and Hopkins, and I'm well aware of group health, and I'm glad they're changing their image because when I lived in Seattle, we sort of used to refer to them as group death. But Dr. Wennberg, let me say I've had a knee replacement a couple of years ago. I'm very happy with it, but I was older when I had it, so it was a decision that I made. And I think back to what you're talking about, shared decisions. With my parents, it was always the doctor knew the answer. The doctor knew what was best. We didn't talk about it. And I know my pediatrician made house calls. Times have changed. Doctors are specializing. Shared decision making. I hope the younger generation will start to ask questions and challenge doctors' recommendations. I certainly agree with you. A couple of things I would like to throw out to you. I'm sorry, the congressman left. I believe we need some competition in healthcare. I don't know if I'm on Medicare now. Is it great? I don't know. I'm not sure. I don't think know if it works that well. But should patients be able to interview docs? If I want to find a doc who's good, I'm going to ask someone or get a referral, and there are different kinds because docs are specializing now, whether it's an orthopedic doc who's going to do the shoulder to the waist, and then the waist to the foot, cardiology. Everyone's specializing rather than your primary doc. And how do you deal with the issue of confidentiality with regard to outcomes with patients? And I have to tell you, I am really amazed that you're talking about not knowing outcomes, whether you've worked in a teaching hospital or you have UA stuff that, quality assurance. It amazes me that you don't know about outcomes because I guess I've worked on grants and you always have to show outcomes in order to get more money. Docs have patients, they keep stats. So how do you deal with confidentiality? How are you going to deal with Medicare patients and Medicaid patients with regard to reimbursements to docs if you want a single payer system and no competition?
I'm sorry. I'm going to compress your question into
alternative medicine
and focus on the outcomes issue.
Yeah, and alternative medicine as part of this. And thank you.
So I wanted to just point out the issue with outcomes isn't, I don't believe, Dr. Wennberg's limitation. It's the limitation of data. So yes, there's lots of outcomes in hospital. They can tell you in-hospital mortality rates and so forth. they often don't know actually whether a patient has been readmitted to another institution and so forth. Some of this is protective of specific hospital interests and so forth. So absent that information, it's very hard to know what happens to people over time. So some of my colleagues actually write papers because there is one commercial database that has claims compiled for people from multiple settings, so you can actually look out over time. So if someone has bariatric surgery, for example, you can see what the complication rates were at 30 days, 3 months, 6 months, and so forth, how often they had to be readmitted anywhere, or had to come back to an emergency room, and so forth. So I think Dr. Wennberg's point about putting data together is, and when he talked about all payer as opposed to single payer data, was just that we would be able to see, because there's a lot of interactions between multiple different payers in the system that sometimes cloud our ability to view. So it's harder to make nice maps like the Dartmouth Atlas.
Jack, I'd like to give you the opportunity to either answer the question or to make one last comment.
Oh, well, I think that that question has been dealt with as well as I could do that. I just want to thank you for listening and asking questions, and I hope you'll go out and solve the variation problem.
Thank you. All right. Thanks very much.
Thank you.
So their books are for sale, I think,